Morning, everyone. I am CHOO from Aju University School of Medicine. It's my honor to present this great joint international symposium. My presentation today is Imaging for Castration-Resistant Disease. What is necessary? Imaging for CRPC is to exact staging for predicting treatment response and prognosis, and making optimal target lesion for evaluating treatment responses. It's also for the prevention of possible adverse events such as spinal bone fractures. And also, there could be found possibility for the local treatment while metastasis-directed treatment. Importance of imaging in CRPC is well known. Prostate-specific antigen alone is not reliable enough. Visceral metastasis may develop in men without large PSA. Many expert consensus recommended that treatment should not be stopped or changed for PSA progression alone, but at least two of three criteria that including PSA progression, radiographic progression, and the clinical deterioration should be fulfilled to stop treatment. Usually we use conventional imaging including CT, MRI, and bone scan, but there is some limitations. So next generation imaging including PSMA PET CT with various stop or fluocyclovine PET CT or colon PET CT and whole body MRI is now emerging next generation imaging techniques. Limitations of CT and MRI. CT shows a poor detection rate of bone metastasis, and there are limited assessment for the lymph node metastasis. Pooled analysis showed the sensitivity for CT to find lymph node metastasis is only 42%, and specificity was 82%. MRI has long examination time, and it also limited assessment lymph node metastasis. The sensitivity was 39% in pooled analysis. Limitations of bone scans are it is not prostate cancer specific. It is only an indirect measurable tumor activity based on osteoblastic activity, and the quantity of disease is difficult to measure in bone scan, and the interpretation is subjective and relies on manual assessment of lesion number, size, and intensity. Also, it has inherent delay for the complementary scan. It's known as 2+2 rules. PCWG3 recommendation shows that two new bone lesion and two another lesion and consecutive bone scan. So in that patient, new lesion was found in week 9, but it was not a progression, and the another two more lesions was found in week 37, and is confirmed in week 49. And then week 37 is the day of progression, but it was determined at week 49, so the delay was about 3 months. Next generation imaging, including PSMA PET CT, shows hiding metastasis, which is not found in conventional imaging, such as MRI, CT, and bone scan. Prostate-specific PET registers, including PSMA, choline, and fluocyclovine, also shows good sensitivity and specificity. The report about whole body MRI showed good result and they reported two-thirds of metastatic lymph node was located outside the pelvis, which is not covered with salvage pelvic radiation. Some imaging tools are tumor-directed and another tools are bone-directed. So to find the metastasis, which method is better is depending on the patient condition or metastasis extent. A report from Copenhagen University showed the comparison of PSMA and sodium fluoride and whole body MRI for the detection of bone metastasis. PSMA and sodium fluoride PET CT shows good sensitivity and specificity, but whole body MRI showed some positive result in negative metastasis patients. Generally, detection rate of colon and PSMA PET CT showed similar, but in patients with low PSA, PSMA PET CT showed better detection rate. PSMA PET CT is useful for the early or mCRPC. One study to evaluate the 55 patients with early CRPC defined as PS level is under 3. Any positive rate was 75%, and distant metastatic disease was found in 45%. Another research for the mCRPC, so it was multicenter retrospective study, and 200 patients with high risk conventionally mCRPC patient and who was PSA was over 2.0 and PS doubling time is lower than 10 months or Gleason score is over 8. All patients was found no metastatic lesions in conventional CT or bone scan, but at PSMA PET CT, 55% had one digit and one disease. So PSMA PET CT is very valuable for the detecting early metastasis in CRPC. Limitation of PSMA PET CT is that the expression of the PSMA is not uniform. PSMA expression has markedly inter or intra-patient heterogeneity. So 27% of mCRPC tissues have no detectable PSMA. Even in same patient, bone metastasis showed marked PSMA expression, but lymph node metastasis showed no expression. Vice versa is also possible. So one study compared FDG PET CT and PSMA PET CT. 23% of patients has at least one PSMA negative but FDG positive lesions. Generally, PSMA showed better sensitivity, but there are some lesions which is only positive in FDG PET. Also, there is some lesions only positive in PSMA but negative in FDG PET. So, what can I do? Should we do everything we can do? But the problem is the cost. So the ASCO guideline for imaging for mCRPC recommend NGI can be offered only if a change in clinical care is contemplated. CRPC patients with compound metastasis on conventional imaging, NGI should not be routinely applied, but sometimes NGI may play a role if it is performed at baseline and to facilitate comparison of imaging of progression of disease. There is some recommended features for additional imaging. Exclusively visceral metastasis, or predominantly lytic bone metastasis, or bulky lymphadenopathy, or bulky tumor lesions, low PSA levels with multiple bone metastasis, or any sign of or any features of neuroendocrine markers. Clinicians want to do everything, but the hurdle is cost issues. PET CT is expensive, and new drugs and new treatment modality is also more expensive. Higher cost may be a barrier to the initiation of and the adherence to the recommended cancer treatment. So, tailored discussion and decision making for each patient is important. Thank you for your attention.